I hope you guys are all doing well with the course materials. It looks like assignments are flowing in pretty steadily and everything's looking great so far from what I can see. So awesome job. Keep up the great work, everyone. I look forward to seeing you guys in lab, not this week, but next week, July. I wanted to say it was the 7th, but I think it's the 8th, whatever that Tuesday is. Um, Today we're going to be going over chapter 16 and chapter 17. So chapter 16 is all about reassessment as a part of our medical assessment. So you can see I've got up here on my screen the patient medical assessment that we were working with last week. If you haven't already started to memorize this assessment and kind of dig deep into it, I strongly, strongly, strongly recommend that you start doing so. This assessment is the bread and butter of not just EMS, but pretty much any medical field that you go into. How we assess our patients is literally like the job, right? So we got to make sure that we're doing a good job with it and getting our questioning down and understanding the priorities of our assessment, what needs to come first, second, etc. So just to recap, first part of our assessment is the scene size up. This starts as soon as you get into your truck. Scene safety, looking at what the scene is like when you get there, and it's not necessarily things like what weapons are on scene, but things like ice or dogs or angry neighbors can all be a part of scene safety. Do you have your appropriate BSI or PPE on? And then what type of call is it? Is it a nature of illness? Is it a call where we need to have additional resources because of how many patients there are? And then do we need any C-spine precautions for our patient or patients? From there, we move on to our primary assessment. Our general impression is, are sick or not sick when looking at the patients? You know, what did they look like? And then moving on to level of consciousness. For this, we use AVPU, alert, verbal, painful, or unresponsive. And if you want to get fancy with it, we can add the Glasgow Coma skill as well, although that's kind of a little sprinkle. It's a little extra for this particular class anyways. From there, we move on to chief complaint. What is going on with the patient? And this is what they tell us is going on. And then our airway, is it open? Is it going to stay open? Breathing, what's their rate, rhythm, and quality of respiration? Circulation, is there any blood that we need to take care of? What's their skin condition like? What's their pulse and pulse quality? We're not necessarily worried about pulse rate at this point. More or less, you know, is it there is a big part. And then determining that transport priority. So do we need to go fast or do we need to go slow to the hospital? Or even if you're not working for a transporting service, do the transporting services need to speed it up and get on scene so that they can get to the hospital? From there, we moved on to our secondary assessment, and this is all about our history taking. We've got our sample and our OPQRST, so signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to, as well as the onset, provocation, quality, radiation, severity, and time of injury. And then we throw in our vital signs. Remember, we've got those 6 normal vital signs that we should be getting on every single patient. And then we do have our 2, I like to call them bonus vital signs. They're not technically ones that your book says to do on every patient, but they are really good ones. If you've got the time, they're really good ones to add in there. Temperature can tell us a lot. And if we've got a patient that we're not really sure what's going on with them, blood sugar can tell us a lot as well. So today we're talking about the reassessment. That is the next and last part of this medical assessment. And this includes the vital signs. So we're always going to reassess our vital signs. That's how we get trends for our assessments. We want to see if our patients are trending upwards or downwards. We're redoing our primary assessment, we're redoing the secondary assessment, and then we're looking at any interventions that we have done, seeing if they need to be changed, altered, updated, discontinued, anything like that. So it's important to note, and I think I'm going to do it while we're looking at this. I think it's a little bit easier to understand kind of if you can see it as opposed to just talking about it. But the primary assessment and secondary assessment, there's a lot here that we don't need to reassess. We're kind of using our critical thinking skills to narrow down what we need to reassess, right? So for instance, allergies. What are you allergic to? You ask it once, they tell you, oh, I'm allergic to bees. 5 minutes later, when you reassess your patient, you don't really need to ask allergies again, right? It probably hasn't changed in the last 5 minutes. Medications, same thing, right? It hasn't changed. Past medical history, if they were vague on this answer, we can go in a little bit more depth with this. But again, in 5 minutes, it probably hasn't changed much. Same thing with oral intake. Events, I like to kind of use this as a time to like ask further questions like, okay, you said you were mowing your lawn when this happened. Was there anything different about you mowing your lawn this time? Were you drinking a little bit more alcohol than you normally would before you did this? Or were you doing anything abnormal leading up to mowing your lawn when this started? Things like that, just to go a little bit more in depth with everything. Onset doesn't really change. The QRS in our OPQRST is the part that we really want to focus on. Quality, radiation, severity. That can change. Well, yeah, we're just going to leave it at that. That can change. So how does it feel like? Does it move anywhere? And what is the severity? Some of our interventions can change this, hopefully for the better. But also with our patient, and say it's a heart attack, if the heart attack is getting worse, these are going to change, right? So we'll focus a lot on that. Vital signs, out of these vital signs are, well, the three lowest ones here. Pupils, temperature, and blood sugar, those probably aren't going to change. Big one is like if you're dealing with a patient that has blood sugar problems and that's why you were called, we're probably going to check blood sugar a few additional times. And then say if they've got like a head trauma where we're worried about intracranial pressure, we'll reassess pupils multiple times. Otherwise, the rest of them you should be doing every single time. Primary assessment, what are we reassessing with this? Well, sick or not sick is always something that we want to throw in there. Actually, let me take this back. We're pretty much doing the entire primary assessment again. So sick or not sick, what's their level of consciousness? Has it changed? Has the chief complaint changed? If it's something like chest pain, maybe their chest pain is resolved with the medications that we've been able to give them. Is that still their primary complaint? Or are now, since we've gotten rid of the chest pain, are they complaining more of dizziness or nausea or something like that? Airway, breathing, circulation, always we want to make sure that we're going back over and reassessing that, and then determine to transport. This will change a little bit depending on whether or not you're working for a transporting service. I saw when you guys were introducing yourself on Schoology, I did see that quite a few of you are planning on working for services that do in fact transport. My cat is going crazy right now. So a bunch of you guys are planning to work for transporting services. So in this case, when you're reassessing your patients, we do have the ability to fix a few problems. Granted, not a lot of problems, especially not at the EMR level, but we can fix a few. So if the interventions that we've done have corrected the problem, we can go from fast to slow. Or if problems are getting worse, we can go slow to fast. All right, let me pull up the PowerPoint. I think I covered a lot of it, so we're going to skip around a little bit here. Again, I respect your time. I don't want to be repeating myself too much, especially since this is a relatively straightforward assessment or portion of the assessment, since we've already gone in depth with the rest of it. Big thing here when we are reassessing is that we want to identify any changes or any trends. So with those vital signs, where's their blood pressure going? Is it continuing to rise and elevate? Is it getting lower? With our interventions, have things kind of normalized? Where are we at with everything, right? This cat is driving me nuts today. Changes can definitely be subtle. So we'll work on this, the identification of it, as well as kind of going in depth with what those subtle changes can mean. Pulse pressure is a big one that we talk about. So pulse pressure refers to the difference between the systolic and diastolic number. So as that number gets closer and closer together, that means something versus farther and farther apart. That also means something. So we'll talk about that a little bit more later on. We definitely want to be continuing to communicate with our patient throughout this entire process, explain what we're doing, explain why we're checking things. I've mentioned this before, but our patients, no matter if they have a history of chronic anxiety or not, they're always dealing with some sort of anxiety within the call, right? Whether it's, I've never been in an ambulance before, or I don't really like it when strangers come into my house and now there's 3 of you all here at the same time in my house. It might be something that they're, I just lost my train of thought there, but there's always a little bit of anxiety. So talking to our patients, explaining what the next steps are going to be, explaining kind of our thinking process is big. Communication is huge. I'm a huge proponent of that. It helps so much. Also, it's really nice when you're working with your partners, when you are thinking out loud, they know where you're at in the assessment as well. So I've had it a few times. This is me as a paramedic working with an EMT, but we had a patient that was having chest pain, but also had some facial weakness, and it was kind of a, is this a stroke, is this a cardiac issue type of call. He was thinking it was more of a stroke. I was thinking it was more of a heart attack, but we kind of went through the whole process, and he was kind of not necessarily interjecting per se, but kind of adding some questions in here or there that let me know that he was thinking it was more of the stroke, which I was kind of blinded to at that point. So we kind of went down both roads, kind of explored both possible opportunities, and it turned out they ended up having a huge aortic aneurysm dissection, which is kind of a, it's kind of a weird cardiac incident, right? As far as how it presents. It's not your classic like substernal chest pain. It comes with a lot of other symptoms, and it doesn't really show up on 12 leads, which we tend to rely a lot on. We always want to reassess for life-threatening problems, of course. That's our airway, breathing, circulation, altered mental status, or where their mental status is at. If we do happen to have a patient that is altered, now we've talked about this last week as well, but not only asking like, oh, hey, are you alert, but also asking like, where are you at? What's your name? What's going on? If they answer one of those questions incorrectly, and that's abnormal for them, we do like to revisit those questions and see if they can remember. And it might not be something specific like, do you remember your name? But it might be like, okay, they don't remember what year it is. Well, maybe we can go and see if they remember what day it is or something like that. Just asking additional questions there. When we have unresponsive pediatrics, babies specifically, we're going to flick the bottom of their feet. That's their painful stimuli. With adults, we typically do sternal rub. You can also do clavicle twists. I'm kind of a fan of that one because this is kind of the jaded side of me a little bit, but working in lacrosse, we would have quite a few people that we're really good at kind of faking things, right? So painful stimuli, if you're expecting it, you can work through it, right, and not react. And there were people that were getting really good at that. So clavicle twist is another one. You just take 2 fingers and you can do it on your own clavicle, but you find the clavicle and you just twist slightly with your fingers. There's a whole bunch of nerves right there, so it does kind of hurt. But if you're not expecting that pain, it's harder to not react to it. So like I said, it's kind of my jaded side. But anyways, that's what we do with adults. Peds, we flick the bottom of their feet. Sorry, like I said, I'm just trying to figure out what all I need to mention here. So interventions, I know we haven't talked about like what interventions we're going to be doing. We're kind of learning the skeleton of the assessment first, right? Bare bones, like what are the steps, right? From here on out, we're going to start adding to the assessment, right? We're going to start adding, tendons and muscles and all the fun things to our skeleton to kind of flesh it out a bit, right? So we are going to do interventions as we come across problems. So interventions could be things like delivering oxygen or splinting or medication delivery, any of those things. All interventions, anything that we're going to be doing to the patient. So in this case, obviously we haven't talked about it much, but fix as you find is kind of the saying that I go with. I find that it's easy to remember, right? So we're going to fix as we find. When we get to the reassessment portion, we're going to go back to the things that we've done to our patient, and we're going to reassess that specific intervention. So in this particular picture, it looks like he's bandaged some sort of injury on a wrist. So we'll go back to that bandaging. We'll look at circulation. We'll make sure that the bandage is still on appropriately, like the tape isn't falling off or something like that. We'll make sure that the injury is not bleeding through, all of those things. And we will go a little bit more in depth what you need to be checking with these interventions when we go through what the interventions actually are. Observing trends we did talk about already, but just kind of keeping track of where those vital signs are at and what they're doing. Small amounts of fluctuation is normal, right? Your blood pressure, if you take it 1 minute versus 5 minutes later, it's probably not going to be the exact same, especially since we're humans and there's going to be some room for error just in general, but it should be pretty similar, right? 2 to 5 points is pretty standard deviation, right? If you start getting any bigger influx, there's a pretty significant change there. The other thing is if we have, say, like a 2-point increase from one to the other, and then the next set we get another 2-point increase, then we start to realize that, okay, their blood pressure is going up, their heart rate is going up. Stable versus unstable. So when we reassess our patients, we always want to be reassessing them at a certain interval. The book says stable patients we're doing every 15 minutes, unstable patients we're going to do every 5 minutes. I get where they're coming from. It's nice to have a black and white answer as far as when do we reassess our patient. We don't want to be taking vital signs on them continuously, right? We'll give their arm a break from the blood pressure cuff. But even though you have this black and white answer of every 15 minutes stable, every 5 minutes for unstable, we still want to remember that if we see any changes, like with mental status, or we're talking to this patient, all of a sudden they're unresponsive, or all of a sudden they're like, oh my God, my heart is just racing, that's going to trigger us to reassess the patient sooner, right? We're going to immediately go into a reassessment as opposed to like, oh, well, I'm sorry, your heart's racing, but you still got 9 more minutes before I can reassess. Right, we don't do that. But that in a nutshell is reassessment. So this was a fairly straightforward chapter. I think I've said that about all the chapters. I'm sorry, I need to stop saying that. I get this is new for all of you guys. As always, the PowerPoints are available to you online. So if you do want to go through the chapter review, you're more than welcome to. If you have any questions, let me know. All right.